today we are going to do part 2 of my discussion with Dr. Corinne Menn. If you're interested in more information, if you're interested in watching the other half of this discussion, I'll link it down below. I welcome any comments and questions in the comment section because I'm going to have more experts on this channel going forward. So I'm going to roll part 2 of my discussion with Dr. Menn, and I will see you on the other side. Let's talk a little bit about length of time on HRT. Assuming someone is in that 5 to 10 year window and they start on HRT, what is their time frame? Is there a stopping point, or can they be on it indefinitely?
So it's great that the Menopause Society really updated their guidelines on this, because this was a confusing point that I think a lot of people are still kind of relying on the old language from their 2017 statement. But basically, the evidence says that for a woman who is otherwise healthy and doing well and feeling good on her HRT, and she has no new contraindications, and she evaluates at least, once a year with her healthcare provider, kind of, her medications, there's no reason that you should arbitrarily just stop it just because it's been 5 years or 10 years or 12 years or 2 years or whatever it is that your doctor tells you, right? Here constantly, you've been on this stuff long enough, time to get off, right? Mm-hmm. Like, it's just, there's actually no reason. There's no data. And I can tell you, if you go to the Menopause Society conference and you look at this room of menopause specialists and you ask any of them who are menopausal, who are on HRT, if they ever plan to stop it, I doubt you will find a single one.
Right.
These are the experts, right?
Right.
So, and it's because there is no reason. And we can't confuse that. So what I see people all the time is like, well, I've been on it for more than 10 years. I hear there's this 10-year window. I guess I should stop at 10 years. Yeah. No. We're saying there's an ideal time to start it because your tissue is healthier and you're going to have the most benefits. But you can go beyond 10 years if you've been on it for a while. A common thing I see at Alloy is that I see women coming to me because they were on it for 15 years, or a 72-year-old woman, like, I've been on it for 20 years. I'm fine. I'm good. I'm living my best life. I have a new GYN and she refuses to renew my prescription. And I'm like, but why? Now, she's not the same as a 72-year-old coming to me the first time and saying, Doctor, I've never taken estrogen. I am diabetic and hypertensive and I'm obese and I've got this and that. And I think it's going to make me feel better. No, you're a different person, totally different scenario. But I think that 10-year thing gets people really confused.
For
and
sure.
Also, the 10 years, remember, it's 10 years from your last period. So this age of 60 is kind of silly because there's tons of women who go through menopause at 57 even, 58. And 10 years brings them out to age 68, So those are little nuances that are important.
I definitely do want to touch on this a little bit because I think it's important for people to know. I just would love to hear how you are providing access, because that is a resounding message over and over and over, is no access to. I mean, even if they have a doctor, the doctor won't talk to them about it, or they can't find a doctor. Can you just explain a little bit about what you do at Alloy, what you do, your consulting, and explain that access to people?
Yes. So Alloy was started by Anna and Monica, who both, for various personal, reasons that they experienced where they were not getting access to the care. And they're like, this has got to change. Let's do something about it. And so this idea of, kind of leveraging technology and telehealth to provide access in all 50 states to NAMS, or Menopause Society trained, physicians, to provide access to FDA-approved hormone therapy prescriptions, but also just access to the information, right? And so that's what I do at Alloy. That's kind of their mission, not only to provide prescriptions, but also provide a platform for, information. They have support groups. There's tons of educational material. We're always doing webinars with leaders in the field, like Dr. Haver, Kelly Casperson, and tons more. Our chief medical advisor, Sharon Malone, is really on a mission to educate, in a perfect world, everybody would have their neighborhood OBGYN who would be totally up to date, have, availability and not book 9 months out, and actually have the time to spend. But we don't live in that perfect world. So, so that's why, I do that on Alloy. I love to do it on social media because it's, to me, it's like, it's like volunteer work, frankly,
Yeah,
in terms of just
absolutely.
getting the message out, to people who I think are marginalized, especially like breast cancer survivors or people who have just been denied access. And then in my private practice, I do that for the handful of states that I have chosen to do telehealth for. And then for people who don't live in those states, I do just patient education only consults where I'll basically be a navigator, tell them what they should be getting, and help them find doctors where they, can get access. Other places that are great for women. So the Menopause Society has a list of NAM certified providers. That's a great place to start. Another resource that not as many people know about, but they should, is the International Society for the Study of Women's Sexual Health. ISWISH is an amazing organization, really dedicated to sexual medicine, which overlaps a ton with menopausal medicine. So really, any of the providers on the ISWISH provider list are generally quite well versed in this. And both organizations have really good patient education resources. So I always tell women, don't just Google it, pick a few trusted resources, because there's a lot of junk out there in
Yeah.
terms of information.
I
And then,
will definitely link everything that you just said so that people will have will be able to get to those resources, because I definitely, over and over and over, you just hear that people are lost. They're just lost, and it's almost shocking. And this is like volunteer work as far as I'm concerned, because likely the women that are clicking on this video need this information.
yeah, absolutely. And I think that, telehealth, what I do at Alloy or what I do in my private practice, I always tell women, I'm not replacing your gynecologist. I'm not replacing your internist. It's consultative, it's specialty care, and it's just another resource so that you can get access. I think we complement, your primary care doctor, who is really, or your general OB/GYN, who's really just overburdened and probably just a little bit undereducated in menopause. And when they realize, like, oh, you're getting good, reliable information from like board certified doctors who get it and care and are providing like ethical, evidence-based treatment, because there's a menopause care vacuum
Yes.
out there.
This conversation happens, and the more that people get the right information, we're all going to be better for it, because there will be a tipping point where it can't be ignored. It can't, but we all have to have the information. We have to have the right information, which is key. So testosterone. I'm just curious your take on testosterone, the value of it, and anything that you can share with us about testosterone.
Sure. Yeah. Listen, there's clear guidelines on the use of, appropriate testosterone in, women, specifically for, low libido, hypoactive desire disorder is, the official terminology, right? So that's kind of the primary way we think about using it. There's plenty of data that testosterone may be helpful in other ways, maintaining skeletal muscle. It may help women who have, really severe vasomotor symptoms and they're not getting complete relief. It might be particularly important for all the surgical menopause ladies out there. Because remember, when you go through natural menopause, you still have your ovaries intact, and your postmenopausal ovaries are still making low levels of testosterone. That testosterone gets converted to low levels of estrone and other estrogens. And, you have some hormones going on, right? When you take out your ovaries, you are removing your primary source of testosterone. So I would say that's one case where I'm a little bit more apt to be that much more, quote unquote, aggressive with offering it. So in the rest of the cases, my approach, and I think this is generally kind of the approach that most, NAMS doctors would kind of, would support, is that when we're talking about testosterone, first we need to talk about, are you sleeping? Are we treating your hot flashes appropriately with your, your estrogen? And if you need progesterone, if you have a uterus, are we treating your genitourinary syndrome changes so that you don't have pain with sex? We need to optimize those things first, because when we throw a whole lot of hormones at once, we don't know where side effects are coming from or what's really working. So I typically will start with, more standard HRT for women. After, say 3 months or a period of time, if they're still having, symptoms of low desire, or And they've also done the work, because remember, sexual dysfunction, low desire it's not just testosterone. It's a whole sort of things. It's a biopsychosocial model. We have to kind of hit it from all angles. If we're doing that, we can offer testosterone as one of the tools. And the fact that it's controversial, we don't have access to it, it's difficult to get, all these things is crazy, because it's not a gendered hormone. Biological women, biological men, everybody makes testosterone. And, so yeah, there might be, good uses for it. And ISHWISH and NAMS and ACOG have extremely clear prescribing guidelines. We do not, pellets are not the way to go. You can use male products in much smaller amounts, or that's one case where you do get it compounded from a reputable compounding pharmacist, right? So that's a use. And like I alluded to, the women who I'm particularly, interested in and helping with that is, well, anyone asking for it, certainly they deserve access, but these surgical menopause women, or very premature surgical menopause. And I think there's a lot of emerging data on that it's actually can be protective on the breast when used appropriately. Yeah, but this is another dimension that we're just tapping into, unfortunately. But and we don't prescribe it. I prescribe it in my private practice. We don't prescribe it on Ally, because telehealth platforms, you have to be very careful. It's a controlled substance to stop.
Yeah.
So it's not as easy to always prescribe online. So it's a little harder to get, unfortunately, but you can go to ISHWISH, or I'm a NAMS provider, and you can get access.
So if you have, like, for example, with my mom who had breast cancer, are there any tests that I should do before I'm on, because I mean, it used to be, or it was my understanding that I'm at this 25% more increased risk of breast cancer myself. I, for a short time, avoided soy. And I mean, I thought now I'm kind of like, oh my gosh, but I didn't, it's just crazy. But so now I think, well, there's gotta be a lot of people who have a mother who has, is there something special they're supposed to do? Or are they just like everyone else as far as going through this,
two answers to that question. The first is, yes, you should always know your family history, and you should always know your risk factors for breast cancer, right? And if you are a candidate for genetic testing, which many women are, so if you have, first degree relative, with breast cancer, with ovarian cancer, multiple relatives with breast or ovarian cancer, or even other cancers, uterine cancer, colon cancer, on both mom's side and dad's side, you should talk to your doctor about getting tested for any genetic mutations, because then we would do enhanced surveillance, and we would give you prevention options, from surgeries to medications and such. So that's super important. So that's what you should do different, in terms of, like, make sure you're getting your proper screening, and preventative guidance. But it's super important. If one message I get out from this whole, talk today, it's that Menopause Society, the guidelines, that, it all states that the preponderance of evidence tells us that your breast cancer risk is here, and whether you use hormone therapy or not, it's still here. So using HRT to treat your symptoms doesn't further increase your risk. So, for instance, women who carry the BRCA1 and 2 gene, who still have their breasts, some of them have lost their ovaries because they had them out to prevent ovarian cancer. Others just went through, menopause naturally and still have breasts and ovaries. Those women can still get HRT, but I literally did a reel on it yesterday. They're constantly being denied. They have not had breast cancer yet. They're just at an increased risk. So, and what's great is I have good evidence to back me up. Like, there's a practice protocol, there's a clinical statement on this. Like, we have lots of data. So I always mention the BRCA mutation carriers, because they're amongst the highest risk. Right. Really, there's a ton of your listeners out there who probably just have a family history, but they haven't found, had a mutation, or they have fibrocystic dense breasts, or, some other factors that they've been told raise their risk a little bit, which is true, So that's super, super important. And remember in the WHI, HRT, when given in estrogen alone, women had a up to 30%
Right.
decrease risk of getting breast cancer,
Right.
a large decreased chance of dying of breast cancer. So I think that's reassuring. And we talked earlier about how if you add the progesterone, and that if it's a regular bioidentical micronized progesterone, it doesn't further increase your risk. So, you know, I'm really black and white about it. Is I don't think it increases your risk. We've got tons of data to support it. You should not be denied access. And you shouldn't ignore changes in your breast. Listen, I was 28 when I was diagnosed. I didn't have any family history. I turned out carrying the gene,
Yeah.
having stage 2 breast cancer. But yeah. And then Dr. Avram Blooming's
Yes.
book, Estrogen Matters. I mean, that's a whole nother webinar. You should just have him on one day and he'll talk to you about it. But, he'll talk about that and also how we can even use it in breast cancer survivors who are appropriately counseled and, given, shared decision making and risks and benefits.
And so I think we hit it all. We went over sleep, but maybe we could just touch on it really quickly. Last thing here, and the question is, what is the cause of the waking between 2 and 4 at night? I mean, is that the dip in estrogen? I mean, can you explain some of the science behind that?
Yeah, I mean, I think it probably, so nighttime awakening, probably has many factors for, different women. But we do know that the dip in estrogen, as well as the kind of erratic changes in progesterone production, definitely causes that and contributes to that. And, the kind of the nature of night sweats happening and waking you up. And we know that, insomnia begets more insomnia,
Yes.
and sleep begets more sleep. It's actually becomes a habit. Why is it that you wake up sometimes at a certain specific time? It's almost like your brain is getting changed. It's being reinforced behavior. It's the same reason why, people over time, have a wake up time. They always get up at 6 o'clock, even if they don't have an alarm. Well, if you're woken up every night, midnight with at 3 a.m. with a hot flash, night sweat, it becomes like a habit, So that's how part of hormone therapy helps with those nighttime awakenings is stopping the trigger. But I do notice that sometimes even women were, all right, I'm not getting the night sweat anymore, I'm still waking up. And I think that's when we have to really, really double down on like really superb sleep habits. And when you mentioned cortisol, I'm not, an expert on that science in sleep, but from a common sense standpoint, anxiety, stress, anything that raises those cortisol levels are all going to be associated. And that's why it's so important getting back to like that very holistic, approach. From just a little like tip, if you are on your HRT and you're feeling great and you don't think you need more estrogen, meaning you don't have, any more hot flashes and night sweats, but your sleep's a little bit disturbed, ask your doctor about bumping up from 100 milligrams to 200 milligrams of progesterone. Sometimes a little bit of progesterone extra is just we know there's a direct benefit on the GABA centers in your brain, and NAMS references using up to 300 milligrams of oral micronized progesterone for this. So sometimes you don't even have to raise your estrogen more, just add a little bit more progesterone and that could be helpful.
Yeah, and I think that if we can stay asleep, I mean, obviously we stay asleep because that's obviously a high Captain Obvious. But I mean, once you wake up because you have to pee or because you had a night sweat or whatever, then your brain can take over and then you're doing this. And so that's a whole different thing as to why you're staying up, And so it's almost like Dr. Haver was mentioning sleep hygiene and maybe don't drink as much water close to bed. There's so many things that we can try and do so that we don't wake up and then all these things take over and we can't go back to sleep.
That was the biggest problem for me for years. And what I found anecdotally, what works for me is I do use a sleep mask so that no extra light comes in. It really helps me stay asleep. And I have these cute little like headband earphones so that they don't hurt my ears. And if I'm up and I don't go right back to sleep, I never go on my phone.
Right, right.
Online. The worst thing you can do is this.
Absolutely. And I'm definitely guilty of that. I do try really hard because I know that, I mean, it's funny. When I was a lot younger, we didn't have phones, but like if I watched television or something, I'd fall asleep to it. But as I've gotten older, it's the opposite. It'll keep me awake. And so I think to myself, don't get on your phone. You don't need to check, whatever news, or any of it. So, well, I would love to know if you have any insight into systemic estrogen and its effects on skin and that kind of thing.
Yeah, sure. This is an easy, question, and it's written right in the, Menopause Society guidelines, So we alluded to earlier that you've got receptors for estrogen, everywhere in your body, including your skin. And we know that women in the first 5 years of menopause will lose like 30% of their collagen, right? So it's the collagen is starting to break down, fibroblast activity, which are cells that like help produce elastin and collagen and, the support structures of your skin. Also, your skin produces its own hyaluronic acid. All of these things kind of slow down and there's a loss there, and we know there's tons of data that systemic estrogen therapy will help stop that and really help improve the skin quality, plumper, more blood flow, thicker, less dry, better wound healing. And I actually, because you are PENN.SMITH and you care about skin, I made sure that like this is exactly what it says in the menopause study guidelines. Estrogen has beneficial effects on skin thickness and elasticity when given at menopause. It promotes collagen, elastin, hyaluronic acid, makes skin feel plumper, more hydrated. There's not enough data on if it will preserve or stop hair loss. There's some data that it might help there. So yes, so they talk about it. Doesn't mean that that's the primary reason you should start it, of course. But to discount that a woman who is complaining of those skin changes shouldn't have that as part of her discussion with her doctor is silly. And then that leads to, the topical use of it. We spent a lot of time talking about how it topically helps in the vaginal tissue, the urethra. I'm sorry, your skin in your face is no different. It's skin down there, it's skin here, so topical estrogens, yes, there's lots of literature and data. There's not an FDA approved topical product. At Owley, we do prescribe a compounded product, or you can speak to your own doctor about that. And so that is certainly an option, and it's not for systemic hormone therapy. It's topical, just like we use topical vaginal, estrogen. And I think the reason why the dermatology industry, hasn't jumped on this is because of the WHI. When I was looking into this about a year ago and learning more about like the skin aspect of it, I saw all these papers and these discussions that were published after the WHI. And in it, it would say, because estrogen therapy is dangerous, because estrogen therapy causes breast cancer, we have to find alternatives to this. So it was almost like there was definitely interest in the skin application before the WHI. And you can literally look at the research. It all halts from dermatology journals then. And then there's a company that was doing like an estrogen-like, compound, not estrogen. So there's maybe merit to what they're doing, but the reality is it's almost like it doesn't need to be done because it was being done because people were afraid of estrogen. You know?
And let me one more thing. I know that people are going to ask, because you are on Alloy, you are people able to request you?
Well, so technically no. So if I'm licensed in your state, you will probably get assigned to me. Although I work with my other colleagues are also, we share states, right? Yeah. So we all work together. What I can say is you can mention that you heard me talk, or so if there was a point that I make, brought up, or you've heard me talk on social media that maybe your doctor who you're assigned to didn't address with you, you could just be like, hey, will you ask Dr. Menn, because we all work together.
Wonderful.
And I will also assure you that we're all NAMS trained. Most of us are NAMS certified. everyone. We participate in, we just did it yesterday, actually, monthly doctor's hours where we talk about cases. And yeah, so I think you're in good hands with anybody, but
Yeah.
they can always kind of tag me.
I really, really appreciate your time today. And I do hope that when we get all of the questions that we're going to get, that maybe we can do a follow-up sometime in the future.
Totally. I love to talk about it. It's like my mission.
I think it's wonderful. And again, I'm going to reiterate that I'm going to link your Instagram, all of your socials and everything. I'm going to encourage everyone to, of course, follow you. Provide such a wealth of information on the internet. And I appreciate that you do that as well. All right, you guys, thank you so much for tuning into this 2-part little series with Dr. Corinne Menn. Leave any comments or questions you have down in the comment section, because I'm going to have more experts on this channel, and I will do my best to get every single question answered, provide all the resources that I can. I'm also going to link my alloy down below. Use it if you need extra help with your menopause symptoms, if you need more information, etc. It's a great resource. I hope that you're having a really, really wonderful day, and I'll talk to you in my next skincare video. Take care.